All right, let's talk about something that could have a massive impact on your health, but you've probably never even thought about it. We're going inside the world of hospital data quality.
I mean, seriously, just think about that for a second. What if your birth year was off? Or your weight had a misplaced decimal point? It might seem like a tiny little thing, but in a hospital, those details, well, they're anything but trivia.
And that's really the heart of the matter. We're not talking about some messy spreadsheet for a business report. In a clinical setting, a data error isn't just an IT problem, it's a patient safety problem. Every single number, every entry, it's all part of your medical story. And getting that story right is absolutely critical.
So what do these data errors actually look like? Well, they usually fall into two main buckets. Two hidden dangers that clinical teams are always on the lookout for. Okay, so on one side, you've got missing data. These are the blank spaces, right? The empty cells where some really important piece of information is supposed to be. And on the other side, you have logical errors. Now, this is where the data is actually there, but it just makes no sense. It's information that is physically or clinically impossible. Let's dig into both of these.
An empty field in your medical record isn't just neutral, It's a void. It's like a key page has been ripped clean out of your story, and now your doctors are left trying to guess what was on that page.
And to give you a sense of the scale here, just look at this. In one real-world case, a full 8% of chemotherapy patient records had a totally blank field for known allergies. 8%. Just stop and think about the potential danger hiding in that number.
This is the huge problem with that blank space. It creates this incredibly dangerous ambiguity. A doctor sees that empty field and has to ask a critical question. Does this mean the patient has no known allergies, which is fine, or does it mean we just don't know, which could be catastrophic? When it comes to your safety, the difference between those two is everything.
Then you've got the other danger, these logical errors. And this is data that just flat out defies reality. You see things like a patient being discharged from the hospital before they were ever admitted, or a male patient who's been diagnosed with pregnancy, or a medication dose that's 10 times higher than it should be, or an adult patient whose weight is listed as 3 kilograms. These aren't just simple typos. These are huge red flags that can lead to devastating medical mistakes if they're not caught.
So, when you're facing down dangers like that, how do hospitals fight back? Well, they've got a whole playbook with incredibly high standards, all dedicated to one thing: keeping data clean and keeping patients safe. Let's take a look at what that really means.
To really get how high these standards are, let's start with the world of scientific research. In that world, a lot of experts will tell you that if more than 20% of your data is missing, the validity of your entire study is kind of questionable. So, having 80% of your data is often good enough.
Okay, now let's get a little closer to patient care. When you move into clinical studies, the kind of research that might actually inform how doctors practice medicine, that standard gets way tighter. Here, you generally want less than 5% of your data missing. We're getting much stricter, but this is still the world of research.
But when we're talking about the data that is being used to make decisions about your care, we're talking allergies, diagnoses, medication dosages. The goal is on another level entirely. We're aiming for less than 1 or 2% missing data. The standard isn't just high, it has to be practically perfect, because anything less puts your health at risk.
And what happens when an error is found? Well, the process is really clear and methodical. First, an automated system usually flags a potential problem. That's step 1. Step 2, a human, a member of the clinical team, has to investigate. They have to go back to the original source, the paper chart, the lab result, and find the truth. And finally, step 3, the record gets corrected, and just as important, that correction gets documented.
Of course, all this hospital data doesn't just live in one tidy little spreadsheet. It often has to be connected to all sorts of other sources, like research data or financial reports, and that brings a whole new set of challenges.
To connect all these different data sets correctly, you basically need 3 key things. First, you need a common identifier, like a unique patient ID, so you can link records from one system to another. Second, you got to make sure everyone's speaking the same language. Does the word inpatient mean the exact same thing in both data sets? And third, you have to be comparing apples to apples, so similar groups of people over the same period of time. If you don't have those 3 things, you're not going to get a clear picture.
Now, this whole idea of comparing similar groups brings us to a really useful concept from the world of epidemiology. It's called prevalence. All it means is the proportion of people in a very specific group who have a certain condition at a given time.
The absolute easiest way to think about it is just to ask this simple question. Out of 100 people in this group, how many of them have the condition we're looking at?
That's it. It's just a percentage that tells us how common something is within that specific population. And this is why context is just so critical. For example, a big study of the general population might find that the prevalence of diabetes is about 10%. But then you look at the patient data from one specific hospital and you see 30%. Now, this doesn't mean one of them is wrong. It could just mean that this particular hospital is a referral center that treats way more complex diabetes cases. They're two totally different populations, and if you tried to compare them directly, you'd come to a completely wrong conclusion.
So, after looking at all these dangers, these intense standards, and the complexities of it all, what's the final diagnosis? What does this all really mean for you as a patient?
It's actually really simple. Good data is good medicine. This whole process, this almost obsessive focus on quality, it's not about keeping the spreadsheets looking neat. It is a fundamental part of keeping patients safe from harm.
You know, in a lot of other fields, high-quality data is a nice-to-have. But in healthcare, no way. It is a core, absolutely non-negotiable pillar of providing safe and effective patient care, period.
And that really leaves us with one final big question to think about. As medicine becomes more and more reliant on algorithms and automated systems, who is ultimately responsible for making sure the data's story is the true story? Is it the system, the doctor, the patient? That's a question we're all going to have to answer together. Thanks for watching.